welcome to Learn from the Case. How are you? Today I want to talk about two types of tumors of the central nervous system, pilocytic astrocytoma and primary central nervous system lymphoma. This is due to a case that occurred a few years ago in the neurological care center where I was attending, and recently I saw the patient again and learned that he is now cured. This patient was transferred from one neurological center to another because he had moved. At the beginning of the investigations, he had been preliminarily classified as a patient with primary central nervous system lymphoma. And then, in the first center, it had begun to be suspected that it was actually pilocytic astrocytoma, something that was later confirmed in the final neurological care center where treatment was also given. This was a few years ago and I do not have access to the research, but I remember that it was because the MRI suggested that it could be primary CNS lymphoma. And since this person was 61 years old, he had also been taking corticosteroids daily for a suspicion of rheumatic polyarthralgia. Was never confirmed, but his family doctor had started this cure with corticosteroid, and the patient, despite not showing any improvement or change, continued taking the medicine. And as one thing led to another, this person moved, renewed medicine with a new doctor who didn't do so much research either, and then the pandemic came. The patient didn't go out so much, and so he was on corticosteroid 5 to 10 milligrams per day at least for 1 to 2 years. Crazy. When another doctor returned to the question of the prescription and inquired further, he learned that the patient did not need to continue taking that medication and gradually weaned it off. But months later, the patient began to have headaches that were new for him. He had never suffered that before. In addition to mild nausea that occurred almost daily in the morning and memory problems, which he did not verify, but which those around him had noticed. So he went to this new primary care doctor, and after 2 visits, they decided that the central nervous system needed to be evaluated with diagnostic imaging, which I think they ordered MRI from the beginning. Upon seeing the space occupating mass compatible with neoplasia and relating this to the symptoms, the age, and the fact that the patient will have, at least in theory, iatrogenic immunosuppression due to the corticosteroids that he took daily, it was initially suspected that it would be a primary CNS lymphoma. In addition to the fact that he had started with neurological symptoms after stopping the corticosteroids. You will see why I emphasize this. But later, he obtained the diagnosis of pilocytic astrocytoma, and this made a big change, since the first type of neoplasia does not respond well to surgery, while the other does, and with total resection, when it is achieved, the patient is cured, and that was the case for this person. This patient told me that I could calmly talk about his case and even give personal details such as his name, but in this case it is not necessary, and we can protect the patient's privacy despite having his consent. From here I send him my greetings, love and respect, and I celebrate with him that he has managed to recover. It fills me with joy, as you can imagine. Congratulations. Actually, pilocytic astrocytoma is a type of brain tumor that predominantly affects children and young adults. Despite its relatable benign nature compared to other forms of brain tumors, understanding pilocyticastrocytoma is crucial for timely diagnosis and effective treatment, because, as I said, the treatment of choice is total resection, and if it is achieved, the patient can be considered cured. While primary central nervous system lymphoma are a rare variety of non-Hodgkin lymphomas that constitute about 4% of central nervous system tumors, primary cerebral lymphomas present around the 6 decades of life and clinically manifest with cognitive impairment, headache, and focal neurological deficits. According to some studies, 75% of patients had only one intracranial lesion, and the remaining 25% have between 2 and 4 lesions. Primary CNS lymphomas is defined as lymphoma limited to the craniospinal axis, which includes the brain, spinal cord, cerebrospinal fluid, and vitreoretinal space, without systemic disease. This disease seems more in patients with human immunodeficiency virus infection and in other immunocompromised people. Primary CNS lymphoma related to immunosuppression are almost always associated with Epstein-Barr virus. Unlike other types of patients with primary CNS lymphomas, patients with a disease related to immunosuppression almost never exhibit a phenotype of activated B-cell origin. On CT scans, ring enhancement is seen in 50% of patients with acquired immunodeficiency syndrome, whereas only homogeneous enhancement is almost always seen in patients without AIDS. The median overall survival in published clinical trials typically range from 2 to 5 years. There are poor prognostic factors for patients with primary CNS lymphoma, and they are as follows: age over 60 or for some data over 65 years, elevated serum lactate dehydrogenase concentration, high protein concentration in the cerebrospinal fluid, involvement of non-hemispheric areas of the brain, periventricular, basal ganglia, brainstem and cerebellum, simultaneous intraocular disease and brain involvement. When the tumor progresses, it is usually limited to the CNS or the eye. To rule out occult systemic disease, positron emission tomography and computer tomography of the chest, abdomen, and pelvis are performed, and sometimes a bone marrow biopsy is performed. Even cytomorphology analysis, immunoglobulin heavy chain rearrangement, polymerase chain reaction, or meningeal enhancement on magnetic resonance imaging are ordered. Although more than 95% of patients with primary CNS lymphoma are lymphoma of B-cell origin, patients with CNS lymphoma of T-cell origin showed no difference in clinical presentation or outcome. Almost all primary CNS lymphomas are non-germinal center activate B-cell subtype lymphomas. Primary CNS lymphomas closely resembles the activated B-cell subtype of large B-cell lymphomas, with additional mutation in the B-cell receptor signaling pathway. Primary CNS Hodgkin lymphomas also occur sporadically. Surgery in the case of primary CNS lymphoma is generally not a treatment option because this neoplasm usually occurs deep and multicentric. It is best treated with radiotherapy and chemotherapy, usually cytosine, adenosine, and intrathecal methotrexate, but it usually responds well to corticoids, which, although they do not cure the neoplasia, can reduce the size. That is why the biopsies are taken before giving corticosteroids, and that is why they also perhaps suspected lymphoma in the first neurological center that saw this patient, because his symptoms began when he stopped taking the corticosteroids. And in the treatment of patients with HIV, antiretroviral therapy is of course part of the treatment. On the other hand, pilocytic astrocytoma is a rare tumor with a predilection for pediatric patients, generally located in the posterior fossa. It usually presents with symptoms of hydrocephalus and increased intracranial pressure, and less frequently with epilepsy or focal neurological deficit. The study of choice is magnetic resonance imaging, in which a lesion with solid and cystic components is observed without perilesional edema. The treatment of choice is total resection, and if it is achieved, the patient can be considered cured. Symptoms of pilocytic astrocytoma vary depending on the location and size of the tumor. They commonly include neurological symptoms like headaches. They are often more intense in the morning and may be accompanied by nausea or vomiting. Seizures. They can occur if the tumor irritates the electrical pathway in the brain. Balance and coordination problems, especially common when the tumor is located in the cerebellum. Cognitive and behavioral changes. Memory loss, difficulty retaining new information and remembering past events. Personality changes, sudden changes in behavior, mood swings, or increased irritability. Physical symptoms like visual disturbances, blurred vision, double vision, or loss of peripheral vision, weakness or numbness often affect one side of the body. Diagnosis of pilocytic astrocytoma involves a combination of neurological examination, imaging studies, and histopathological analysis. A neurological examination is the first step, which evaluates motor skills, sensory function, and cognitive abilities to detect any abnormalities. Radiological images, MRI, the most effective imaging technique for detecting pilocytic astrocytomas, provides detailed images of the brain and the spinal cord. CT scan, used when MRI is not available or not feasible, helps identify the location and size of the tumor. Histopathological analysis is necessary to confirm the diagnosis. During this procedure, a small sample of tumor tissue is removed and examined under a microscope to determine its nature. The exact cause of pilocytic astrocytoma is not known. However, certain genetic diseases, such as neurofibromatosis type 1, have been linked to an increased risk of developing this tumor. The treatment of pilocytic astrocytoma depends on several factors, including the size of the tumor, its location, and the patient's general health. The main treatment modalities include surgical intervention, complete resection. The goal is to remove the entire tumor, which is usually possible because the edges of the tumor are well defined. Partial resection, if complete removal poses a risk to critical brain functions, a partial resection may be performed to relieve symptoms. Radiation therapy is usually reserved for cases where surgical resection is not possible or if the tumor recurs. It involves the use of high-energy radiation to attack and destroy tumor cells. Chemotherapy, drug therapy may be considered, especially in young patients or when the tumor cannot be removed surgically. It involves the use of medications to kill or slow the growth of the tumor. Although pilocyticastrocytoma are more common in children, they can also occur in adults. Symptoms, diagnostic methods, and treatment options are similar, but the prognosis might vary. Adults might experience slower disease progression. I wanted to present this case because it is very anecdotal and satisfactory because of how everything turned out for the patient. But in the future, I will try to present more typical cases of CNS, lymphomas, and astrocytomas. And with this last thing, I say goodbye today. As always, you're welcome to leave me your comments or questions. Thank you for the attention and be very, very well.